Welcome to WellBe, AmeriMed MIH Community Paramedicine Education, and thank you for attending this training. Thank you for your time, and most importantly, thank you for your continuing efforts to provide a superior level of both patient care and customer service. We appreciate the challenge and the shift from EMS to community paramedicine procedures.
This is the in-service training for AmeriMed Mobile Integrated Health Community Paramedicine Program with WellBe on how to use the Zoll E-Series monitor to pace a patient in a bradycardic symptomatic rhythm. A scenario would be that there's an APC on scene and we arrive shortly after they've made patient contact, and a patient is not feeling well at this point. They've gone through their procedures to decide that cardiac monitoring is appropriate. We get orders to begin monitoring from the APC. We approach our patient, but they're that gray enough that we're concerned that we are going to put pads on them, so we place our pads on them. And initially, don't ever go straight to pacing. Turn on and see what you have. And initially, we have this, and we're starting to collect more history. And then our patient starts to look sweaty and feel worse and gets a little woozy. And then we start to see this on the monitor. We feel for a pulse. She does have a pulse. It's 42, but it's no longer on radial. It is now only carotid, so she is now meeting criteria for an unstable bradycardia. And we have discussed with the APC atropine versus pacing. Because the patient is unstable, we are going to pace first, and then may consider other agents or other treatment paradigms at that time. So to pace, before we go into the pacer mode with the Zoll E-Series, it's important to make sure that your milliamps are turned all the way down. There's a white volume icon here. So we go this way to go all the way down, and that's, you won't see it on the screen until we go to that menu, but you just want to make sure that you are turned down. You don't want to go to pacer and be at 80 milliamps and start pacing right away. So we have turned that down. Okay. We now go to this screen, and following these prompts, then confirm on the right side, and we are now in the manual mode. Notice that it's saying the EKG leads are off. You cannot pace with the Zoll E-Series just through the pads. You have to have the limb leads and the pads connected. So our monitor is saying we have our limb leads on now. We already had our pads in place, and we are seeing 0 milliamps. However, there is a small spike here, which is our pacer spike. And clearly we have disassociation between pacer spike and patient's QRS. In AmeriMed Mobile Integrated Health Community Paramedicine Program, the recommendation is to be between 70 and 80 beats per minute for your rate that you are going to set someone to. And so we will set that before we increase our milliamps. In this particular case, they're at 42. Basically, when I am feeling for a pulse, when the pulse from the machine is double what the patient's natural pulse is, I'm likely to be able to sense that, and so I know that I've got mechanical capture as well as electrical capture, because our first stage is electrical, and then we need to ensure we have mechanical. There's no point from a patient outcome perspective to only have electrical. You must also have mechanical. So now that we've set our rate to 80, we see our patient's rate is still 42. We're going to start to increase our milliamps. Counseling may be appropriate if this patient is still alert enough to communicate. However, if the patient is not, it is important to get the capture and reperfusion as soon as possible, and we can coach the patient once they are more alert and perfusing better if it gets to that point. Do not delay starting pacing because of concern about patient discomfort from the procedure. We're now up in the 60 range. Still, this pacer pulse is separated from the patient's QRS, so we are still dissociated. We will continue up. You can go up to the maximum on the Zoll monitor for the number of milliamps. So we are now starting to notice a change in the patient's QRS, and we now have a pacer spike with the patient's ventricular deflection. So we would say this is electrical. We are going to check for a pulse. At this point, it is important to do the pulse distally, away from your pacer pads, as the contortions of the chest from the electrical delivery can cause you to feel what you think is a pulse when it is just the contraction of skeletal muscle around the vessels. So going either femoral or radial, or even pedal, check, and if you feel a pulse that is around 80, remember before you would start this process it would have been around 40, so a doubling of the patient's pulse, then you know you also have mechanical. At this point, you have mechanical. We'll argue at this point we still don't feel the pulse, so we're going to continue to go up, and then if we get the pulse at 80, we have mechanical here. As a general rule, our patients are at home. This could be on a pacer for a significant period of time. It is appropriate to increase past the minimum about 10 or 5 milliamps to increase the chance that we do not have to deal with a loss of mechanical capture because of a change in conduction, either through the patient's skin or through these pads as they deteriorate over time. So this would be a great time to take a picture of your screen so you know what your rate is set at and what has worked. It will also give you, either off of your phone's time-stamping capability, it will give you a timestamp of an important event in the patient's pre-hospital treatment. Now that we have mechanical capture, we can continue with discussion with the APC about next interventions.
If you discover ways of executing on these tasks smarter, better, or faster, please tell your training officer immediately. Thanks, and as always, be safe.